So I'm going to be giving the next talk, and I'll introduce myself a little bit to those of you who don't know me. I'm actually a pathologist, and if you remember Dr. Warner's diagrams of multidisciplinary care, the pathologist is one of the members of the clinical team. Sadly, most people don't know they're a pathologist because pathologists usually don't meet with patients. Some people call pathologists the physician's physician because we really work behind the scenes in the laboratory doing the lab tests that are relevant for your doctors to help manage your care. So as a lab physician, I work in a laboratory, I do pathology, I run labs that do things like chromogranin assays and so on. And I want to just give you a little bit of my perspective on more of the biology of the disease so you understand what it's about. I have a lot of slides, and I've prepared these for you, and if anybody would like the slides to review some of the details, I'm more than happy to share them with you. So I'm not going to read the objectives or the outline because that's just to get you going. But in terms of what I want to talk about, I'd like to clarify some of the issues about these different kinds of dogs. Because really it's the pathologist whose job it is to classify which kind of dog you're dealing with. So I want to start from fundamental basics and just tell you a little bit about the endocrine system. The endocrine system is basically a system of cells that sometimes form organs in the body, and the job of these cells is to secrete hormones. That's what endocrinology is all about. And there are different kinds of endocrine cells. So if you look at throughout the body, you get hormones made by different parts of your body, including, for example, your ovaries and testes. Those are endocrine glands, but they're not part of what we're talking about today because they're a very different beast. They're not even a dog. They're a different species altogether. So what I've done on this slide is tried to tell you a little bit about where different hormones come from. There are cells that are actually modified neurons. They're like brain cells, and they make some hormones. And those are cells that we call either paraganglia or pheochromocytoma cells. And they're very specialized neuroendocrine cells, but they're a little bit different from the other neuroendocrine cells that we're talking about mainly today. Now, I noticed that some of you actually may have tumors that derive from these modified neuronal cells. And so if anyone's interested, I'm happy to talk about those, but I didn't really tailor my talk to that today. I want to make a point, though, that when we talk about some of the imaging and therapies, it's very important to understand the distinctions between these different kinds of cells because, for example, MIBG is a tool that we use very often for patients with neuroendocrine tumors. But if you understand the biology of the different cell types involved, MIBG is very heavily taken up by cells that are of this type. So if you happen to have a paraganglioma or a pheochromocytoma, MIBG is going to be a very good test or therapy potentially, whereas it's not so good for patients who have other kinds of neuroendocrine tumors. The neuroendocrine epithelial cells are really the ones I want to concentrate on today. And the drawing that I've given you on the right here is actually a series of drawings of what happens during embryogenesis. So we all start from one cell, and that cell multiplies, and then those multiplying cells go into different parts of the body and develop into different organs and have different functions. All of the things I'm talking about really are relevant because the cells come from different places and specialize in different ways. So the cells that I'm talking about in the neuroendocrine epithelium are actually cells that at one time were actually thought to arise from the neuronal precursors, like the first group. But we now know that that's not actually true. They actually arise from the endoderm, from the, in embryogenesis, the gut that goes all the way from the mouth to the anus. And those cells actually will involute and separate or differentiate separately into cells that are modified to be able to function like neurons in that they can secrete hormones and secrete peptides. But they are probably not actually of neuronal derivation, which is why they are a little bit different and they don't, for example, take up MIBG as well. In terms of the pathology, there are very different markers that we use. Chromogranin is expressed by both of these families, and that's why it's such a good marker. But there are other markers like tyrosine hydroxylase that will distinguish the modified neurons from cytokeratins that are expressed in the cells that come from the GI tract. So of all of these different tumor types, They all have different markers, they all have different biologies, they secrete different hormones, but the interesting thing is that they sometimes can kind of cross paths a little bit. So we have to think about that when we're dealing with individual patients who have different kinds of tumors. I'm not going to talk about thyroid follicular epithelium or steroidogenic tumors, but I do want you to concentrate on these neuroendocrine tumors. And when we talk about neuroendocrine tumors, we don't usually have difficulty when the tumor is in the pituitary, when it's in the parathyroid. Those, because they're endocrine organs where these cells all cluster together, when a tumor develops there, clinicians never really have too much difficulty understanding what it is or where it is or why it's there. The difficulty is with the tumors that are kind of spread throughout other organs like the lung, the GI tract, and in the pancreas, because there are other kinds of tumors that can develop there too that have nothing to do with neuroendocrine differentiation. They're what we call exocrine tumors. So that's kind of a very long introduction to what it is that we're going to talk about. Here it is in pictorial form. This is somebody else's illustration of an endocrine system with specific organs and other components that make hormones. What we are talking about are distributed neuroendocrine cells, for example, in the thyroid or in the lung or in the gut. And actually, this is actually a really nice picture that shows you, this is the gut in a normal person. It's seen through the microscope at very high magnification. And you can see here that most of the cells are actually negative, but there's a little tiny cell in there that's staining for chromogranin A. And that is a normal neuroendocrine cell living where it belongs, doing its job, making hormones to regulate the gut. And the tumors that we're talking about today actually come from that cell. And here's another example. This is a very pretty picture of an islet of Langerhans, which shows a cluster of neuroendocrine cells that you can readily see are different from the surrounding cells of the pancreas. So these cells live in different environments in different parts of the body, and they do different things. And when they develop into tumors, they form tumors that are a little bit different from the other kinds of tumors that we see coming from non-endocrine cells. And I just want to spend a minute talking about terminology. The term carcinoid was actually originally derived from carcinoma-like. It was actually originally coined by Obendorfer, who was a pathologist working in Istanbul in the 1930s and 40s. And Obendorfer recognized these funny tumors that arose in the lung, in the gut, and in the thymus. And he saw that they were different. As Dr. Warner very nicely said, they were all like dogs. They may have looked different from each other, but they were dogs as opposed to horses or cows or something else, which were the more common tumors that arose in those sites. And in his original description, these were usually found as incidental autopsy findings, and they seemed to be very localized and not very aggressive. Even though they looked a little bit like carcinoma, they didn't behave like malignancies. Now, the problem with the terminology carcinoid is that it has given people the understanding that these tumors are not aggressive and they're not malignant. They're carcinoma-like. They are not carcinoma. And that's actually not true. So what happened historically is that the term then went on to be associated with the carcinoid syndrome that we now recognize in some patients who have some of these neuroendocrine tumors, and specifically the ones that make serotonin. And so my recommendation, and I think many other people who I work with have also come up with these kinds of recommendations, is that we drop the use of the term carcinoid to describe these tumors. Because the problem with the terminology is that it's misleading, and that's why we have gone to call these preferentially endocrine tumors or endocrine carcinomas, depending on whether we know for sure they're malignant or not. It's very hard for any pathologist to tell you that an endocrine tumor is going to be benign, because throughout the GI tract and lung, when we see these tumors, they may look like they're going to be benign, but they may not behave that way. So in summary, I think we need to restrict the term carcinoid to describe the syndrome, which we now all understand. I would suggest that we should not be using the term carcinoid to describe the tumors. We should call them endocrine tumors, and when we know that they're going to behave in a malignant fashion, we call them endocrine carcinomas. Some of you may also know that there are terms like islet cell tumors and apodomas that are more historical that we really don't use anymore. Now, in terms of the anatomic distribution, I think this has already been covered a little bit by some of the previous speakers, and we know that these are very widely distributed throughout the body. I just want to point out that there's 5% in other, so we all think about these as being lung, duodenum, stomach, GI tract, but there are other sites, and I've seen neuroendocrine tumors, for example, in prostate, in ovary. They can occur almost anywhere in the body because these neuroendocrine cells do live, although in very small numbers, throughout other organs in the body. Epidemiology is very interesting. We know that there's these are fairly rare tumors, and that's why the terminology around zebras as opposed to horses. However, I think we do need to understand a little bit more about the fact that the incidence is actually increasing. And that's what I'm showing on this slide. The diagnosis of neuroendocrine tumors has been increasing dramatically over time. And the reason for this is not entirely clear, and I think we all have to be careful when we talk about this. It's true that the diagnosis is increasing. The question is it because pathologists and clinicians are recognizing neuroendocrine tumors more, and we used to call these non-endocrine tumors of the GI tract, pancreas, or lung, or is it that they really are increasing in incidence? And I don't think we have any answers on that. I can assure you, as a pathologist, when I review pathology, certainly in the past there were a lot of misdiagnoses. Now, the clinical and biochemical features you've already also had some introduction to in terms of the function of these cells. I have to re-emphasize for you, and I was very pleased to hear Dr. Warner emphasize how important it is for the pathologist to characterize these tumors properly. I actually get very frustrated when people think that a neuroendocrine tumor is a neuroendocrine tumor is a neuroendocrine tumor, and when clinicians just randomly measure chromogranin A and 5-HIAA. Because I can assure you, if you have an insulinoma, your 5-HIAA level is not going to be high, but you still have a neuroendocrine tumor. Remember, 5-HIAA is only produced by tumors that make serotonin, and that's actually a very small group of these. That's the carcinoids, and that's 50% of the GI and pancreas tumors. It's much less in some other sites. There are other tumors like gastrinomas, vipomas, glucagonomas. You've heard about those. And we need to be doing our job properly to recognize the clinical manifestations that are different in each of these patients, that the hormone levels will be different, and that the function and biology of the tumors may well be very different as well. Another quick comment about chromogranin. Chromogranin is a very useful marker for the vast majority of these tumors, and I want to talk a little bit more about that when I talk about differentiation. Now, in this chart, I'm just giving you some of the correlations, and the important message here is not for you to read this chart again. If you want it, I'll give it to you as a handout. The important thing is that each of these different hormones is secreted by different tumor cell types. And we know in the normal body we can distinguish A cells, B cells, D cells, EC cells, G cells, all the different kinds of cells that make these different hormones. And in well-differentiated tumors, when they start to develop, they usually have the morphology of their native cell type. And they make the hormone that their native cell type makes, and that results in a characteristic clinical syndrome. Now, sometimes tumors can actually play tricks on us. They can make more than one hormone, or they can be silent clinically, and that's really important as well. So now let me just show you some pictures of what these things look like. This is going to be a little hard for the patients to orient, but I just want to give you a pictorial illustration of what it is that you may or may not have had. This is actually somebody's bowel, and it's been opened up. The bowel, as you know, is a long, skinny tube. And what a pathologist does when we get a specimen from the surgeon is we open it up and we examine it. We've opened up the bowel by cutting it, so this is now lying flat. The cut surface has made it opened so it can lie flat on the table. And this is normal bowel mucosa. This is the small bowel. And here you can see this little tiny lump that's hiding here in the background. And this little lump on histology looks like this. So this is actually a cut through that area. And what a pathologist does is we take little pieces of tissue from these tumors, we fix them so they last indefinitely, and we put them into wax blocks and cut very thin sections, onion skin thick, and we put them on glass slides and look at them in a microscope, and this is what they look like. And you can see here, although it's not so obvious on the gross examination, look how obvious that tumor is in the microscope. And the reason for that is that it's got lots and lots of cells with lots of nuclei proliferating. Here's another few examples. These are pancreases from patients who have little pancreatic endocrine tumors. This patient was really lucky and got 2 of them, which already tells us something about genetic predisposition that I'm going to talk about. These can be very small, hard tumors, large, mushy tumors, and giant, very hemorrhagic tumors, depending on what stage we catch them at. Now, interestingly, we can make structure-function correlations. This little tumor is an insulinoma, and we usually pick those up pretty early because they have florid clinical symptoms. This big thing was what we call a non-functioning tumor and was not detected until the mass was felt, which is why it was so big at the time of being picked up. Now, Dr. Warner also showed you pictures of the morphology that we see in the microscope, and while it's true that the cells can all look the same, no 2 tumors ever look the same. And this collage is just a series of different kinds of tumors that are all neuroendocrine tumors. Actually, these all happen to be from the pancreas, but they're all different. And to the untrained eye, they may all look just like neuroendocrine tumors, but to the eye of a pathologist who sees neuroendocrine tumors day in and day out, we actually can recognize different structure patterns in terms of the architecture of these tumors. And I've listed these all on the slide because pathologists love to give names to everything that may or may not be particularly relevant. In addition, we classify them based on their stromal features. This is that little tiny dark tumor, the insulinoma that I showed you. It's got a lot of stromal fibrosis, which is why it was hard and white. Other tumors have calcifications in them, like you can see here. We call these Samoma bodies. All of these different morphologic features actually do mean something, because there is a tendency for different architectural and stromal features to correlate with different hormone production. And then, of course, there's the actual cytology, or what the individual tumor cells look like. This is where it gets really tricky, because there are funny tumors like these clear cell tumors that look more like non-endocrine tumors. A lot of stomach cancers look like this that are not endocrine. There are oncocytic tumors. These are tumors that have pink, kind of very large balloon-like cells that look atypical, and a lot of pathologists can have difficulty with that. And then there are these funny cells we call rhabdoid, because they look like muscle cells of all things, but it's just because they have an atypical cytoplasmic feature in them, and pathologists need to be aware that these can be neuroendocrine tumors. Now, when we're dealing with one of these tumors and we think, oh, could this be neuroendocrine, we need to be able to prove it. And you've already seen a very nice picture of chromogranin A, and that's what's here. Chromogranin A is more or less the universal marker for all neuroendocrine tumors. They're kind of harder to recognize, as you can see on that hematoxylin and eosin stain slide, because sometimes they hide in the normal architecture of the body. But when you do see these tumors and you see that they stain for chromogranin A, you know you're dealing with one of these zebras. The problem is, and this is the comment I wanted to make earlier for the clinicians in the audience, I do want to remind you that chromogranin A is actually a component of secretory granules, which is what the hormone packaging lives in. And while chromogranin A is very high in well-differentiated neuroendocrine tumors, it is lost in poorly differentiated neuroendocrine tumors. So while we know that a patient who has a very well-differentiated tumor has a good prognosis when their chromogranin A is low, that's because the tumor is contained, it's small, or if it's been treated, it's been resected. And as that tumor recurs, the chromogranin A level will go up. But while we're talking about zebras, I want to remind the clinicians that there are also zebras in neuroendocrine tumors, because poorly differentiated tumors will lose chromogranin A, and you may have a patient who had high chromogranin A levels, was operated on, is doing very well, you didn't see a rise in the chromogranin A levels, but the really unusual zebra has lost its stripes and it's still hiding there and growing without making chromogranin A. So chromogranin A is not the be-all and the end-all. You have to be thinking of multimodality diagnosis. There are other markers that we use, and again, I've mentioned this already. We can stain these tumors for almost any hormone and identify whether they're making glucagon or insulin or somatostatin or bombacin or gastrin or serotonin or any of the other weird and wonderfuls. For example, sometimes lung or pancreatic tumors will make ACTH, and a patient will have Cushing's disease, which we usually associate with the pituitary, but these tumors can make it ectopically. Sometimes we deal with tumors that have unknown primary sites. So a patient may present with a tumor in the liver, and that tumor usually, when there's no known primary site, that tumor may not, we don't know where it's coming from. And actually, Maureen has just asked me to comment on the role of fine needle aspiration and core biopsy in making the diagnosis of this, and this is a particularly relevant area because what we usually do in that circumstance is the patient will have a liver biopsy. And that liver biopsy is basically we stick in a very large needle, and that needle is able to pull out a little bit of tissue in the, in the lumen of the needle. It's a very tiny piece of tissue, and many people will say, well, what can you do with that? But pathologists can take that little tiny core, and sometimes, even if they're good pathologists, just by aspirating even with a thinner needle from a tumor mass and pulling out even just a few cells, pathologists can put those on slides and stain them with all of these markers that I've talked about and be able to make the diagnosis of neuroendocrine tumor. Now, is that enough? Well, we actually think not, because if you have a metastatic neuroendocrine tumor in a lymph node or in a liver, we want to know where it's coming from. And in our very sophisticated world today, we've actually learned an awful lot about specific markers that can tell us that kind of information. So, for example, there are things that we call transcription factors. Transcription factors are things that we know during embryogenesis direct a cell to be what it is. And in lung, for example, there's a transcription factor called TTF1, which is thyroid transcription factor 1. It's expressed in lung and thyroid. And in lung neuroendocrine tumors, there's usually TTF1 positivity. So a patient who has a metastatic tumor of unknown primary site deserves to have their tumor tested for that transcription factor to see if the tumor is hiding in lung. Or in contrast, a pancreatic transcription factor or a small bowel transcription factor. These are all very important things that pathologists can do. Now, we've already heard about classification and staging, and you've heard about the well and poorly differentiated cancers, and I've already made my comments that I wanted to make for you about the importance of loss of specific markers in poorly differentiated tumors. You've already heard also about the mitoses and the MIB1 labeling index, and actually I just want to make another comment. You've heard now about Ki67. And Ki67 is a protein that's involved in cell replication, as Dr. Warner told you. I need to tell you that Ki67 is actually also identified in tissue sections, as you can see here, by an antibody that's called MIB1, M-I-B-1. So some of you will ask for your Ki67 labeling index. You should also be aware that the other terminology that's used mainly by pathologists is the MIB1 labeling index. So if you have a pathology report that says MIB1, that is Ki67 or vice versa. So don't go asking if you have one or the other for the one that you don't have, because they are the same thing. So just a few pictures to show you invasion by these tumors. Here's, for example, a nerve with tumor invading all around the nerve. That's a bad prognostic feature. Even if you have a tumor that looks really benign, that's one of the criteria for malignancy. And Dr. Singh has already told you about this WHO classification of neuroendocrine tumors that actually, as he already said, unfortunately does not apply in lung, because lung pathologists want to be very different from everybody else. But I think we are seeing progress in uptake of this for many other of the neuroendocrine tumors, so it's now being applied to pancreas, GI tract, and other sites. Now, you've also seen these charts already about survival based on well-differentiated versus poorly differentiated tumors, so it's very important that pathologists be able to make those distinctions. The other thing that's important and that has happened is the TNM staging. Now, I'm going to fly through a bunch of slides, but I did put these in for the clinicians in the audience. Very important to know about this. But this is now accepted practice. And if there is a pathologist in the room, I'd like them to listen carefully. And for the rest of you who are clinicians, please tell your pathologist. The College of American Pathologists now has on its website for free these staging guidelines and how to handle specimens from patients with neuroendocrine tumors. For pancreatic endocrine tumors, there's a new staging, which, by the way, is different from the old one. The AJCC UICC 7th edition is now out, and the old one I showed you was 6th edition. This includes all of the TNM criteria as well as specific staging subclassifications for pancreas, gastric NETs, small bowel NETs, large bowel NETs, and appendiceal NETs. They're all somewhat different, subtle differences between each one based on data that we have providing evidence for what's important in staging and prognosis. But it's very important that pathologists be aware of this and that they use it in their day-to-day practice. This is what we call synoptic reporting. It's very, very important in every other type of cancer, and we have fought long and hard to make it very important for neuroendocrine tumors as well. So I'm just going to finish with a little bit of pathobiology and molecular genetics. And I'm going to skip a few slides in the interest of time, but I do want to make a few comments for you about what we know and don't know. We know that neuroendocrine tumors have tremendous chromosomal instability. What's really interesting is that the instability seems to differ by tumor types. So that, for example, we could probably distinguish lung from gastroenteropancreatic NETs based on some of the allelic losses that we see in these tumors. And the real question for the scientists in the crowd is, what do these differences mean? Why are they different? They're the same kind of tumor, they look the same histologically, but they behave differently, they make different hormones. Could the answer lie in some of these changes? The other important genetic information that we should be thinking about is what are the familial syndromes that we know, or better yet, don't yet know, that can lead us to understand more about the genetics of this disease. Some of you may be members of families with multiple endocrine neoplasia type 1, others with von Hippel-Lindau disease, or neurofibrosis, or neurofibromatosis, or tuberous sclerosis. We know the genes now that are involved in your familial syndrome if you have this, and we also know that we can look at sporadic tumors and try and see if those genes are implicated there as well. Sadly, the answer so far for most of them is that a very small percentage of patients with sporadic tumors have menin gene alterations, like the MEN1 patients, very, very few with VHL changes, but none of the others are implicated in this disease. So finally, prognostic and predictive markers. We all know about somatostatin as a specific target for both imaging and therapy. It is also detectable by immunohistochemistry, and pathologists can help to identify tumors that are good for this marker. We as pathologists are working on other specific markers that might predict a more aggressive tumor. So, for example, in my lab in Toronto, working with Ranjan Chetty and Stefano Serra, we've done some studies focusing mainly at first on pancreatic endocrine tumors, but we're now looking also at GI tumors for markers like a specific cytokeratin CK19, an adhesion molecule CCAM1, and another adhesion molecule, E-cadherin. Other people have looked at EGF receptors and HGF receptors, and even HER2/neu, which some of you may have heard about in breast cancer, as markers that will predict a more aggressive tumor and actually help us to tell the clinicians early on, before metastatic disease develops, that this patient needs some further therapy. And I'm going to skip these slides because they're more for pathologists, but basically just to tell you that the distribution patterns of these different products will tell us a lot about behavior and disease. So I'm going to just finish up with one more story, and that is, for those of you who have these tumors, is there anything else that we can help you do to predict whether or not you are at risk, members of your family are at risk, or those of us in the general public as well? Well, actually, we're working on a very interesting molecule which is called the FGF receptor 4. And this FGF receptor 4 was always thought to just be a typical single product, but it's now been found that there's actually a difference in this molecule in the transmembrane domain that is encoded by a specific genetic change, and about 40% of us have this arginine allele, and 5% of us actually have two arginine alleles. The 35 have one of each, and 55% of people have only a glycine allele. Now, we've done some studies looking at the impact of this on outcome in disease, and it's very interesting to us that in patients who have pancreatic endocrine tumors, the ones who have an arginine allele do much worse, have a much higher rate of malignancy, much more of a tendency to have liver metastases. And so we're actually using this to develop an animal model where we've made cells, BON1 tumor cells, which are a neuroendocrine tumor, and we're able to make mouse models where we inject these cells either into the flank of the mouse or actually directly into their pancreas to see what happens when these tumors are growing. And you can see that in this mouse model, we actually have liver metastases that develop in tumor cells that have this FGFR4 arginine variant. So these are the kinds of studies I want to encourage the scientists and the physicians in the audience to think about, because what we really need to be doing is moving forward into the future, understanding that neuroendocrine tumors, although they're rare, they're very important. They're clinically and pathologically heterogeneous. As you've already heard, and as I'm sure every one of you who's a patient knows, they're very hard to diagnose. And so one of the things we need to be doing is increasing awareness of this disease and using the data that they're increasing in incidence to our advantage to help people understand how important it is to recognize them. And as Dr. Warner said, make doctors think about those zebras. From the pathologist's perspective, we have to start looking at histologic criteria of malignancy that are better than what we currently have, because right now we really don't know, and oftentimes we're guessing, and sadly, malignancy is often defined only when the patient already has metastatic disease. We need to be looking at the biology and understanding better the targeted therapies, and really understanding genetic and epigenetic changes that predispose people to develop these tumors or to have tumors that become more aggressive. So I would like to finish by thanking you all for your attention. I hope I've helped to clarify some of the issues in this field, and we'll have some discussion, and I'll be happy to answer questions when we have our panel session afterwards.